Welcome to the Deep Dive. We're all about getting straight to the essential knowledge you need, fast.
Yep, cutting through the noise.
And today, based on your revision notes, we're diving right into Barton's fracture.
Ah, yes, Barton's. Important one for the wrist.
It is. And look, orthopedic terms can sometimes feel a bit, well, overwhelming, can't they?
They definitely can. Lots of similar names.
So our goal here is simple. Give you a really clear, high-yield rundown of Barton's fracture. Perfect for your revision.
We'll break it down, make it stick. We've even got a few memory tips lined up.
Exactly. Think of it like prepping with a friend who's already done the legwork, ready to get into Barton's.
Let's do it. So Barton's fracture, what is it? Fundamentally, it's a break in the distal radius, right near the wrist.
Okay, distal radius. Got it.
But the crucial bit, the absolute key, is that it's intra-articular. It goes right into the joint surface.
Into the joint itself. Right. That sounds significant.
It really is. Yeah. That's often why it leads to displacement, the fragment moves. And that intra-articular nature often means surgery is needed to, smooth things out again.
Oh, okay. And you mentioned displacement.
Yeah, we classify them based on which way that broken bit shifts.
Mm-hmm.
Dorsal means it goes towards the back of your hand.
Deep back of the hand, dorsal. Okay.
And volar means it shifts towards the palm side.
Volar, palm side. Got it.
And sometimes you can even get an associated dislocation of the wrist joint itself, the radiocarpal joint.
Wow. So the whole joint can be unstable.
Potentially, yes.
Mm.
Now, the typical cause, it's usually a fall onto an extended and pronated wrist. That specific mechanism.
Extended and pronate, like trying to catch yourself.
Exactly, that kind of fall. And because of where the fracture is, you have to watch out for complications like trapping tendons or even the ulnar nerve or artery.
Ooh, okay. Important considerations.
Definitely. And management-wise, we often lean towards operative reduction and fixation, screws, plates, that sort of thing.
Surgery to fix it in place.
Yeah. But the good news is post-surgery, functional outcomes can actually be pretty good, often excellent with the right rehab.
Okay, that's reassuring. So, quick memory tip maybe. How do we lock this definition in?
How about this? Think Barton's ease, bone break by the back or front, B for back, F for front, dorsal volar, affecting the joint. Barton's, bone break, back front, affecting joint.
Barton's, bone break by the back front, affecting the joint? I like it. Okay, let's talk etiology then. What causes this? You mentioned falls.
Yeah, it's typically high-energy trauma. That fall on the outstretched hand is the classic one.
High energy, so not just a simple trip?
Not usually, no. Think a fall from a height or maybe a forceful sports injury. A direct blow to the wrist can do it too, but the fall mechanism is probably more common.
So the force transmits up through the hands to the distal radius, causing that specific intra-articular break.
Exactly. It's the mechanics of the impact.
Right. Does that mean certain people are more at risk, like specific activities?
Absolutely. Risk factors often relate to activities involving high impacts or potential falls. So participation in high-impact sports is a big one.
Like snowboarding, maybe, or mountain biking.
Perfect examples.
Yeah.
Also, contact sports, where direct wrist impacts can happen. Rugby, maybe martial arts.
Makes sense.
And maybe, obviously, any activity with a risk of falls from height. Construction workers, climbers, that sort of thing.
Okay. So here's a quick question for you listening. A young athlete, say a snowboarder, has a bad fall and presents with wrist pain and deformity. Given the high energy mechanism, which fracture type involving the joint should be high on your list?
Barton's fracture would definitely be a strong possibility there, wouldn't it?
Yeah.
Because of that high energy fall mechanism.
Good point. Let's dig into the pathophysiology a bit more. We know it's intra-articular. We know there's displacement. What's happening biologically?
Well, the core issue is that fracture line running into the joint, carrying a fragment of the articular surface with it, either dorsally or volarly. This disruption means the nice, smooth alignment of the wrist joint is lost. The bones don't fit together properly anymore.
So joint incongruity.
Precisely. And that directly messes with the wrist's biomechanics, how it moves, how it bears weight. It impacts function significantly.
Okay, that makes sense. It's not just a crack, it's messing up the whole joint mechanism. So differentiating it, this seems key. How do we tell it apart from other common distal radius fractures?
Yeah, really important clinically. The main ones you need to differentiate from are Colles and Smith's fractures.
The classic one.
Exactly. Remember, Colles' fracture is typically extra-articular, outside the joint, with that characteristic dorsal displacement and angulation, the dinner fork look.
Dinner fork, okay.
And Smith's is kind of the reverse, still usually extra-articular, but with volar or palmar angulation.
Right, the garden spade.
Yeah, sometimes called that. But Barton's,
Yeah.
the defining feature is that it is intra-articular. The fracture line extends into the radiocarpal joint, carrying that fragment with it. That's the crucial difference.
So joint involvement is the absolute differentiator for Barton's compared to Call's and Smith's.
Primarily, yes. You also need to consider other types of intra-articular fractures, but Barton's has that specific pattern of involving the dorsal or volar rim with the attached carpus tending to subluxate with it.
Okay, clearer now. What about how common it is? You hear a lot about Call's fractures. Where does Barton's fit in, say, in the UK?
Good question. Generally speaking, Barton's fractures are less common here in the UK compared to other distal radius fractures, especially Collis.
So not the most frequent wrist fracture we see.
No, definitely not. While you'll certainly encounter them, they're not the majority. Getting precise UK prevalence and incidence data specifically for Barton's can be a bit tricky sometimes.
Understood. Less common, but important to spot. So clinically, what does the patient present with? What are the key features you look for?
Well, you'll see the usual signs of a significant fracture. So definite pain, quite a bit of swelling around the wrist, and tenderness right over that fracture site.
Pain, swelling, tenderness, standard fracture signs.
Yep. And because of the displacement and the joint involvement, you might see a visible deformity of the wrist. It might not look quite right.
Okay.
Range of motion will be limited, and attempting to move the wrist will be painful. And importantly, given it's intra-articular, you might find some instability in the wrist joint itself when you examine it carefully.
Instability. Okay.
And just bear in mind, the exact look, the deformity, might differ slightly depending on whether it's a dorsal or a volar Barton's.
Right, depending on which way the fragment went. So lots of clues there. How do we confirm it? What investigations nail the diagnosis?
X-rays. Standard wrist X-rays are the mainstay for diagnosis.
Just regular X-rays.
Yep. You need good quality views, usually an AP, anteroposterior, a lateral, and often an oblique view as well.
What do those tell us?
They let us see the fracture pattern clearly, assess how much displacement there is, confirm that it goes into the joint, and check for any other associated injuries or fractures nearby.
Pretty comprehensive then.
Absolutely. Now, in some cases, maybe if the fracture looks really complex on X-ray, or if you're worried about significant ligament damage that isn't obvious, then a CT scan or possibly an MRI might be needed.
For more detail.
Exactly, to get a better 3D picture or look at the soft tissues. But X-ray is usually where you start, and often all you need for the diagnosis.
Okay, X-rays confirm it. Then what? How do we manage a Barton's fracture?
Right, management. It's really tailored to the individual fracture, how bad the displacement is, which fragments it involved, the patient's needs.
Makes sense. No one size fits all.
Not really. But because it's intra-articular and often unstable, surgical intervention is very commonly required.
Surgery again. To do what exactly?
The main goals are to get that displaced fragment back where it belongs, that's called reduction, and then to fix it securely to stabilize the wrist joint. We want that joint surface as smooth as possible,
How do they fix it?
usually with ORAF-F open reduction and internal fixation. That means surgically opening the area, putting the bones back together perfectly, and holding them with internal hardware, like plates and screws.
Plates and screws inside the wrist.
Yep. Sometimes, less commonly, external fixation might be used, where pins go through the skin into the bone and are held by an external frame.
Okay. Is non-surgical ever an option?
It can be, but it's less common for Barton's. If the fracture is very minimally displaced and seems stable, you might consider closed reduction, manipulating the bone back without surgery and then putting it in a cast. But that's quite specific.
So surgery's the more frequent route. What happens after treatment, surgical or not?
Post-treatment care is crucial. There will be a period of immobilization, usually in a cast or a splint, to let things start healing.
Keeping it still.
Exactly.
Yeah.
But then comes the really important part, wrist rehabilitation. Physio is absolutely vital to regain range of motion, strength, and ultimately function.
Rehab, rehab, rehab. Got it. So thinking long term, what's the prognosis like after a Barton's fracture?
It's variable, honestly. Depends on quite a few things.
Such as?
Well, the initial fracture itself. How severe was it? How much displacement was there? Were there other injuries involved?
Okay, it's the injury factors.
Then patient factors come into play, the patient's age, their general health, bone quality, and really importantly, how well they stick to the treatment plan, and especially the rehab.
Compliance is key.
Hugely key. But overall, if it's managed appropriately, good reduction, stable fixation if operated on, and good rehab, many patients can achieve good functional outcomes. They get back to most activities.
That's good to hear. But there are potential downsides.
Yes, potential complications can definitely influence the final outcome, and regular follow-up is essential to monitor progress and catch any issues early.
Right. So let's talk about those complications. What can go wrong even if things seem to be managed well initially?
Several things, unfortunately. Malunion is one that's where the fracture heals, but in the wrong position, not quite aligned properly.
The old crooked.
Essentially, yes. Then there's non-union, which is where the fracture fails to heal altogether.
Doesn't mend at all.
Correct. Patients might also struggle with ongoing wrist joint instability. Stiffness is quite common, and persistent pain can be an issue.
Stiffness and pain sounds debilitating.
It can be nerve damage, like the median or ulnar nerve, or vascular injury,
Yeah.
can happen either from the initial injury or sometimes rarely during surgery.
Nerve or blood vessel problems.
Yes, and a big long-term concern is post-traumatic arthritis. Because that joint surface was damaged, it's more prone to wearing out later on, leading to arthritis.
Arthritis down the line.
It's a definite risk, and all of these complications can, of course, impact the overall function and mobility of the wrist joint long-term.
Okay, quite a list of potential issues. So another quick question for you listening. Thinking about those long-term issues, what are maybe 2 or 3 significant complications someone might face years after a Barton's fracture, even if the surgery went well?
Good question. I'd say persistent stiffness, chronic pain, and the development of post-traumatic arthritis are probably the big ones to keep in mind long-term. Malunion and non-union are earlier healing issues, but stiffness, pain, and arthritis can linger or develop later.
Stiffness, pain, arthritis. Got it. Okay, let's try and pull this all together. A quick recap of Barton's fracture.
Go for it.
All right, it's an intra-articular fracture of the distal radius. Key point. Intra-articular.
Yep.
It involves displacement of a fragment, either dorsal, back, or volar front.
Correct.
Usually caused by high-energy trauma, like that fall onto an extended pronated wrist.
Typically, yes.
It's less common overall than Colles or Smith fractures.
That's correct.
Diagnosis is mainly via wrist x-rays, AP, lateral, maybe oblique.
Standard procedure.
Management often requires surgery, or IF, with plates and screws to restore that joint surface.
Very common approach.
And rehabilitation afterwards is absolutely critical for a good outcome.
Cannot emphasize that enough.
Potential complications are things like malunion, non-union, stiffness, pain, nerve issues, and long-term post-traumatic arthritis.
You've covered the main points well.
And that memory tip again, Barton sees a bone break by the back front, affecting the joint. Hopefully that helps it stick.
Nice summary. It really highlights that intra-articular nature as the defining and often problematic feature.
Absolutely. Well, we really hope this deep dive has given you a solid, clear overview of Barton's fracture, ready for your revision.
Yeah, hopefully broken down nicely.
Definitely keep exploring the topic with your own study materials, too. And just to leave you with something to think about, here's a final thought. We know the wrist joint is complex, biomechanically intricate. So, considering that, what specific factors, maybe in the surgical technique or the post-op rehab program, do you think make the biggest difference in achieving that really good long-term functional outcome after a Barton's fracture?
That's a good one to ponder. Lots to consider there.
Something to mull over. And before we wrap up, don't forget, for more excellent resources to help you smash your MSRA prep, check out PassTheMSRA.com.
And also freemansray.com for loads of free questions and guides.
Both fantastic resources. Right, that's it for this deep dive. Thanks for joining us.